time, and because I think, and I've tried to show you why the clinical questions, the underlying clinical questions are not that easy to formulate and to translate into the estimation of causal estimands throughout the target formulation training. So this is joint work. Is it lagging or is it not? Does that work now? Pointed to the computer. Pointed to the computer. Yeah, thank you. So this is joint work with Florian Joshua, who actually made all of the hard work. And Sophia, both of them, actually the three of them are clinicians. And Kevolos, one is from MT Anderson Center. And this is also forced joint work with my new, okay. I try to explain the genesis of this project about pregnancy. A bit of epidemiology and general information about breast cancer first. As you might know, breast cancer is a frequent disease in women. Actually, 1 woman out of 8 will be diagnosed with breast cancer throughout their lifetime. And most breast tumors, around 80% of them, are sensitive to hormones, which basically means that there are some hormone receptors on the tumor cells that gets activated if they are in presence of hormones, and that triggers tumor proliferation. So that's basically something that we want to avoid. And we call these tumors hormone receptor positive or HR positive disease. And today we're going to focus only on this subtype of breast cancer tumors. And patients diagnosed with HR positive disease are generally treated alongside with conventional treatments like chemotherapy and surgery with a treatment that's called endocrine therapy. It's an hormonal treatment that should be taken for at least 5 years, up to 10 years. And that's an oral treatment. Patients are required to take 1 pill a day for at least 5 years. The thing is, that's a hormonal treatment, and it triggers quite severe side effects, typically menopausal-like symptoms, so that many patients actually struggle to take their treatment continuously, and they might not be adherent to the treatments. So I'm going to present briefly the data set that we used, I'm going to use throughout afterwards, without going into details for the sake of time. But our data comes from the French National Administrative Claims. It's called Système National des Données de Santé, or SNDS. And it roughly it includes all healthcare consumption of all French population, and notably all pharmacy deliveries of that hormonal treatment endocrine therapy. And within this huge data set, we actually did it during my PhD, so it was a couple of years ago, identified and structured a data set of patients with breast cancer that includes now over 370,000 patients. That's a huge data set. And that's the distribution of age. As you can see, breast cancer is quite rare in young women. Actually, 6 to 7% of breast cancer are diagnosed in women aged below 40 years old. However, these patients are generally, on average, diagnosed with disease of poorer prognosis. Okay, so I'm still describing the genesis of the pregnancy project. And to do this, I first need to describe another previous project very briefly. As I told you, many patients struggle to take endocrine therapy continuously and expectedly, and the youngest patients struggle maybe even a bit more than the older ones to take it. And so we got interested in how much is it important for patients to take their treatment continuously? How much can they gain in terms of survival? And when I say survival, and that's going to be true throughout the rest of the talk, I talk about a relapse-free survival, so survival without disease recurrence or death. And so in the previous project, we tried to evaluate the potential survival benefits of interventions that would ensure adherence to the treatment in patients. And to do this, without going into details, we emulated a four-arm target trial with three interventions arm. So those three interventions arm aimed at ensuring treatment adherence, that is no treatment discontinuation. And there are three of them because we evaluated three definitions of being adherent to the treatments. The stringent one is that the patients were required never to stop treatment for more than 1 month throughout the 5 years, then 3 months and 6 months for the third one. And we compared it against a control arm where we did not intervene on the plant therapy adherence. And well, then I'm going to skip all of the details of this first analysis, but if you are interested, this is the reference of the paper. And these are the results that we got by age group. So in blue, the survival, the hypothetical survival under the intervention, the most stringent one, no gaps more than 1 month. I think in yellow, 3 months, in green, the 6 months, and in pink, the control arm without intervention. And what we concluded from this previous study was that, well, whatever the age, there is some survival benefit of adhering to the treatment. That was kind of expected. However, it seems that the younger you are, the more the survival, the greater the survival benefit is. And actually, one of the main conclusions of our paper was that in the youngest patients diagnosed before 34 years of age, the survival benefits of ensuring perfect adherence, that is less than 1 month of treatment gaps throughout the 5 years, could increase. So sorry, the survival benefits was 4.3 percentage points at 5 years, which might seem little, but in breast cancer, which is a disease of fairly good prognosis, at least compared to other cancer, that's actually quite substantial. And so we concluded that further effort should be made to try and improve adherence to endocrine therapy, and notably with a focus on the very young patients. All right, so we published that paper, and for some reason it became quite influential in the clinical community, much more influential than my previous papers before that. And so I was invited to give quite a lot of talks about it. And every time the clinicians were asking two questions. The first one is, okay, that's nice results, but then you were not super specific about the interventions to use to increase adherence, right? How should we do this? And I think to answer these questions, we need to try and understand why patients, and especially the younger patients, are not adherent to treatment. And according to the literature, the main reasons why young women might interrupt treatment is, well, obviously because of side effects, but also because they might have the feeling of not being adequately informed. They might have negative emotions regarding the therapy, or, and that's what's going to be of interest today, because they might have a desire for or experience pregnancy. And why is that the case? It's because endocrine therapy is formally contraindicated during pregnancy attempts and during pregnancy. So they need to stop the treatment if they want to get pregnant. So that's the first question that they asked. The second question was, okay, but how does your results relate, and how do you explain your results in parallel with the results of the positive trial? So the positive trial was a trial published in 2023 in the New England Journal of Medicine. It's a major trial, very influential, which aims at evaluating the safety of interrupting endocrine therapy to attempt pregnancy in breast cancer patients. And I'm going to go more into details afterwards about that trial. But basically, they conclude, that's the conclusion in their abstract, that temporary interruption of endocrine therapy to attempt pregnancy did not confer a greater short-term risk of breast cancer events. Okay, and that's the survival curves in red, the intervention group, and in blue, the control group. All right. So that's a bit surprising, right? Because we've got these results saying that it's super important to be perfectly adherent to the drug, especially in very young patients. Why there is this trial that actually says it's fine, you can stop taking endocrine therapy to attempt pregnancy. And so they were asking, I mean, are these results contradicting yours? And actually, I think there are two possibilities. It might be actually that they are contradicting our results and that they question the validity of our data set and or the validity of our adjustment set for the identification of our causal estimates in the first place. However, I think there is a second possibility, and that's what I will try to show just after, that maybe those results seem in contradiction, but that's only because they're answering different questions in different populations. And to try and evaluate the second possibility, what we did was that we emulated the positive trial with our data set to see if we get the same results and the results of the positive trial. All right, so let's see how we emulated this. So first, I will describe more precisely what they did in the positive trial. So this in the positive trial, first of all, very important, that's a single arm trial. Okay, that's not a randomized trial. Well, that's a bit expected because for ethical reason, you cannot really probably randomize things that relate to pregnancy, but I'm going to go back into this afterwards. So it's a single-arm trial, which included women with hormone receptor positive breast cancer, non-metastatic, 42 years of age or younger, but also that had received endocrine therapy for at least 18 months and up to 30 months at the time of inclusion. And that's important, who wished to discontinue therapy to attempt pregnancy. Okay, so two important things here is that they included only patients who survived without recurrence at least 18 months. Okay, so that's not the same population than our initial population, and this population might consist in patients who had less severe disease at diagnosis. And the second important thing is that their population is a population of pregnancy seekers. And that might as well be a proxy of patients of good general health and of less severe disease, because, well, probably patients with more severe disease might not consider getting pregnant or might be discouraged by their oncologist. Okay, so that's the inclusion criteria. Then the intervention they considered, the patients were asked to discontinue treatment at the time of enrollment, which again must be in between 18 and 30 months after treatment onset, and then to respect a washout period of 3 months, during which you can think of it as a way to wash your body from the drug, okay? So during which they were not allowed to take treatment, so they had to interrupt treatment for at least 3 months, and they were also not allowed to attempt pregnancy. They needed to wait 3 months. And after this, the idea was to give the patients 24 months to attempt pregnancy and get pregnant, after which, even if the pregnancy attempts were unsuccessful, the patients were strongly advised to resume endocrine therapy. but it was not really part of the intervention. It was just like a strong advice. The endocrine therapy resumption was not mandatory. Okay, so that's, once again, it's a single arm trial, so that's the only arm that they considered. And what they did to still try and have a comparison is that they built an external control arm. So they took patients from previous trials, the soft and text trials, and they matched these patients with the positive patients. And so the patients in soft and text that they considered were patients also with hormone receptor positive breast cancer, age 42 or younger, and that had received endocrine therapy not for 18 to 13 months, as in positive, but for 24 months. And also, they could not restrict that population to patients who were pregnancy seekers. I guess because they didn't have that information in the trials. Okay. So two important things here again. One is that this is not randomized, although they match the controls with positive. I still do think that there might be some unmeasured confounding, especially arising from this pregnancy-seeking population. And the second important thing in the interpretation of the results that you need to keep in mind is that the controls were asked to, basically were adherent up to months 24, so 2 years of treatment, but after that they could do whatever they want. Okay, so the control arm was not fully adherent throughout the 5 years, only for 2 years. Okay, so that's a summary of the study timeline for the positive arm and the external controls. Something important to notice here is that their time zero was not the same in the positive trial and in the positive arm and in the external controls. Okay, in positive, the time zero was set as at the enrollment, which was the time of the endocrine therapy interruption, which could be any time between months 18 and months 30. Whereas in the external control cohorts, the time zero was set at 24 months for everyone. And actually, well, I guess they did it for practical reasons. I still do think that it might induce some unfair comparisons between the two groups, especially because we expect small differences between the two groups, and so that I think that might be important. This 6 months difference in time zone. Okay, so these are their trial. Now we try to emulate it using our data sets. So actually, to be fair, we didn't really emulate the positive trial, but an idealistic version of it, where we, and that's questionable actually, but we just emulated an idealistic version of it, where we try to remove the drawbacks of the flaws of the trial with this misalignment of time zero and the non-randomization. Okay, so we included, well, again, patients with hormone receptor positive disease, age less than 42. And what we did is that instead of including patients at any time between month 18 and 30, we included patients at month 18 and set time zero at month 18 for the two groups. So the patients at inclusions were required to have received endocrine therapy for 18 months. Well, to be more accurate here, because it's a bit unclear what it means to have received endocrine therapy for 18 months, and it was unclear in the trial. Does that mean that the patients were prescribed endocrine therapy, or that they took it perfectly, or that they took it from time to time? Well, our interpretation of it is that they took it perfectly. So to be more precise, we included patients who had never missed more than 1 month of treatment, in the first 18 months. Okay, and obviously we had no information on pregnancy seeking at the time of inclusion, so we could not restrict our population to pregnancy seekers. Okay, so that's the inclusion criteria. Now with the intervention. So as I said, we although positive is a single arm trial, we emulated a two-arm trial. In the treatment intervention, patients were asked to discontinue endocrine therapy at a chosen time between months 18 and 30 for at least 3 months. Okay, so that's the washout period, during which pregnancy was forbidden. Okay, to be more clear, pregnancy was forbidden all the way from inclusion, so months 18 up to the end of the washout period. So that's the treatment arm. In the control group, patients were control intervention consisted in no discontinuation of endocrine therapy between months 18 and 24. Okay, that's to emulate the 24 months of endocrine therapy intake in the matched control group. And this was a bit unclear in positive, but we required that pregnancy is forbidden throughout treatment, so until month 60. Okay, so that's the timeline of our study, where I insist again, the time zero is at months 18 for both groups. Okay, what time is it? Briefly, I'm not going to go into details here. To identify and estimate the hypothetical survival under these two interventions, we use the marginal structural model, which we estimated through inverse probability of censoring weights. And the marginal structural model had a parametric full logistic regression model assumption. And the weights, well, there are actually two types of weights, because you can be censored either because you took endocrine therapy at a time where you should not, or you did not discontinue endocrine therapy. Sorry. Either you interrupted endocrine therapy and you should not, or you did not interrupt it while you should, okay? Or because you got pregnant during the washout period or in the control arm. So the weights were derived from two models estimating both probability at each month and regressing on a couple of covariates, which I'm not going to go into details now. Well, that's a bit blurry, sorry. So that's the results. And that's the results from the positive trial for comparison. So here in red, the intervention arm, where patients interrupted treatments, and in blue, the control arm, and well, that's the same color code in positive. So basically, we were first quite happy with these results, because it seems that we also do not see much of a difference between the two groups, as in positive. However, the big difference is that at 5 years, we got a risk of relapses or death of around 16 to 17% in our cohort, whereas it was only 12% in positive. Okay, so we're quite far away, which kind of suggests that our population is a population of higher risk than the population included in positive, probably because we didn't have this pregnancy, we could not include only pregnancy seekers. So what we did to try and resolve this issue was we actually stratified our population into two groups, low and intermediate risk patients and high risk patients, based on the treatments that they initially received, did they had chemo and for how long, and some tumor biology factors. And when we did this, we were also quite happy because it seems that in the low risk group, we were back with 12% of risk of events at 5 years, so much closer to what they had in positive. So yeah, that we could reproduce the results from positive in this population. However, in the higher risk population, well, first of all, the risk of events are much higher. That's logical. But also, it seems that maybe there is actually a difference, and that the interrupting treatment, so the red intervention, could lead to higher risk of recurrences. So we concluded that actually maybe the positive trial could not be generalizable to a general population of breast cancer patients, and that actually it might be dangerous and unsafe in higher risk patients. Okay, so we presented this result to the medical doctors we are working with, and well, they all were a bit surprised that, okay, but how does this relate with pregnancy? The interventions you are considering is just like some pattern of endocrine therapy interruption, but like it has nothing to do with pregnancy. And in a sense, they are right, because in our intervention arm, in the uncensored patients, only 6 to 7% of them got pregnant during follow-up, whereas in positive it was 74%. So then the question is, are these results interesting? Like, are we really emulating the positive trial? Are we really answering like a good clinical question? And how do we explain this difference? Something very important here is that it's also the case that in positive there is no intervention on pregnancy. Okay, they are not inducing pregnancy in patients. Well, to be fair, there is an intervention that precludes pregnancy during the washout period, but we also emulated it. But there is no intervention on pregnancy. The pregnancy component of the trial comes from the population because they only include pregnancy seekers. But as I said earlier, we cannot do it. We cannot measure pregnancy seeking in our data sets. So what we ended up doing, and I actually do think, and I explained afterwards why, I actually do think that it's a very unsatisfying alternative, but well, we still did it, is that we implemented in the intervention arm an additional intervention on top of the washout period, where patients would be required to use medical interventions indicative of pregnancy attempts or pregnancy in a timeline that goes from 6 months before interrupting endocrine therapy up to two years after. So that's basically like a proxy that they attempt pregnancy. And it could be either because they start folic acid supplementation, or because they got some fertility test reimbursed, or some assisted reproductive technology, or because they got pregnant. Well, again, without going into details, we did it, and that's the results that we got. Well, there is not much of a difference with what we had before, except that now in the intervention arm, 64% of patients who followed the intervention got pregnant. So we are much closer to the positive trial. Well, so the clinicians were quite happy with this analysis, though I do think that it's a very unsatisfactory results, and that you should be very cautious in interpreting this second results for 2 reasons. Well, actually, I asked the clinicians, why do you think that's an interesting result, an interesting analysis? And they thought of 2 reasons. The first one is that they think that it might enable to reproduce a pregnancy-seeking population, as was the case in positive. Well, actually, it does not. What we did rather was to estimate the effect of an intervention on pregnancy attempts on top of the other interventions, but in the marginal population that includes both pregnancy and non-pregnancy seekers, right? Our marginal population at time zero did not change. And the thing is that first, it's unclear from a clinical point of view, are we interested in the effect of an intervention to, well, help with pregnancy in a population of patients that do not want to get pregnant? Probably not. And the second thing is that I really don't believe that we can reasonably assume exchangeability with respect to this second intervention. For the same reason that we cannot identify pregnancy seekers, there is also probably a measure confounding through pregnancy seeking in our analysis. So I don't really trust our results. And also not sure that they're super interesting from a clinical point of view. Well, a second reason why we might be interested in this analysis is that actually clinicians think that pregnancy in itself might have some effect on survival and disease recurrence. And actually, it's quite interesting because it's super unclear if it were to have an effect. Some would think that it would have a very deleterious effect. Basically, you take like a high shot of hormones in a disease that's sensitive to hormones, so something that you don't want to do. But some others do think that it might have a potential beneficial effect on relapse for many reasons, because you get to, well, you have a family, you have support, you're happy, you're more likely to resume endocrine therapy. And also because it might be that a peak, an intense peak of hormones might act in your body as a stop in producing hormone afterwards. Okay, kind of a retroactive loop. Well, all of these are research hypotheses. So it's very unclear, actually. But exactly because I told you why this would be interesting, I do think that it's not the intervention, pregnancy is not the intervention or pregnancy attempts that the clinicians are interested in the end. Inherently, they are interested in either the effect of an intense shot of hormones or of familial support during treatment, or being happy in general, or returning to endocrine therapy afterwards. And if that's the interventions that they truly are interested in, then why not emulating those interventions rather than the pregnancy one, which is a weird composite of things, which in the end we could not, well, that's not a plausible intervention. We don't know how to induce pregnancy, right? Unfortunately. Oh, okay, right. So to wrap up, in the end, I convinced myself that I do not think that the positive results are in contradiction with our initial results, because I think it's just not the same questions. And I also convinced myself in the end that the results from the positive trial, although it's like a major trial and it's something that's super difficult to work to build, a trial that was super difficult to build, I still do think that the results must be interpreted with great caution for two main reasons. First, as we show, it might be that the pregnancy seeking inclusion criteria might actually be an umbrella for low-risk disease patients, and that we should be aware of not generalizing the results to the whole population of young patients with breast cancer. And the second thing, which I didn't have much time to talk about, but we actually work with it in an extension of our results, is that it's a bit odd, the control group that they set. If I would have conducted a trial, I think I would have set a control group, an intervention in the control group where I would have required patients to be fully adherent to the treatment throughout the 5 years, right? And they only require the patients to be adherent for 2 years. So, well, somehow the comparison is a bit weird, I think. Having said that, thank you, and I'm happy to receive feedback and questions.
Thank you very much, Elise. I think you have
Thanks. So on your slide 29, go one slide. So basically, you are kind of arguing that there are some causal consistency issues if you were to use pregnancy attempt as an intervention, right? So you are saying maybe we can think of that the pregnancy attempt and your child ablation actually be intervening through these possible approaches. So maybe that's not really a well-defined intervention.
Yeah,
I guess.
yeah, that is part of it. Yeah, it's not well-defined intervention, and it's also not a plausible.
Yeah, because if you were,
we don't know how to.
yeah, because if you were to think about a similar intervention in the possible child, that would be to prescribe this pregnancy through recruitment or advertising of that child participation. And I think that would be acting through a very different mechanism compared to what you're trying to advocate using the available data you have in your registry. So I think that's a major concern because pregnancy concern attempts can be like very complicated. It's a lot of factors.
Yeah, I agree. So both pregnancy attempts is complicated, and also pregnancies in itself might act.
Yeah, and another thing is pregnancy attempts should be different from pregnancy per se, right?
Sorry, sorry.
Pregnancy attempts should be also different from pregnancy per se.
Yes, definitely, and yeah.
Maybe that's like adherence.
I think we'll go to here and then let's get to that.
Thank you. Really nice talk. I just wonder, since more and more people seem to be doing single arm trials, and sometimes we go to do emulations to, extend inferences or whatever. Do you see a way in which we could actually emulate a single arm trial? And the second question is, do you think these results support the need for an actual randomized trial answering this question, especially in the context of increased interest in doing trials in obstetrics?
So to your second question, no, I don't see. Well, for ethical reasons, you can randomize pregnancy, right?
So I think that's like the classic approach, but there's an increased push to actually run trials in pregnancy precisely because the evidence really doesn't come from good places. And so, at least in the US, it's been of increased interest to run trials in pregnancy. It's complicated for the reason we mentioned, but the interest is definitely there.
But then I guess they want to run trial in where they include pregnant women, right? Pregnancy is not their intervention, it's in the inclusion.
So it would be some intervention, as you said, women that are interested in getting pregnant, that have taken endocrine therapy, some interesting intervention that would be, more perhaps of the explicit interest of the clinicians and the actual patient.
Yeah, but then I guess there are some interesting clinical questions that relate to this, but then the intervention wouldn't be pregnancy. It would be like, what happened if we were to I don't know, include only pregnancy seekers and then help them getting pregnant by stimulating their ovaries or by doing this or doing that. But again, the intervention would be a bit different. But I do think it's something that we need to work on. Definitely, that's an important topic.
Yeah, absolutely.
It would be one more question.
Yeah, sorry, I got lost when I was saying, but the beginning, but do you think that you censored by upon pregnancy?
Censored by what?
Upon pregnancy?
Yeah, so the intervention was in the intervention arm, patients should interrupt treatments and then they should respect a 3 months washout period where they are not allowed to attempt pregnancy or get pregnant. So patients who got pregnant during these washout periods were not consistent with the intervention, so we censored them and of course we rated.
I would argue that you are kind of the best justifications for what you're doing does involve an intervention on pregnancy, pregnancy. So if your goal was truly to just emulate what the trial got and they did that, then okay, but then they're also not targeting something meaningful. So anyway, we can talk later,
Well,
a little confused.
I'm not sure because what I wanted to, well, at least what I think of it is that it's plausible to think of an intervention where we prevent pregnancy. Okay, that's super unethical, but that's feasible. You can think of like forcing condoms on sexual intercourse or whatever, right? Whereas an intervention on pregnancy in itself is not feasible.
As you're saying, it's not feasible to force someone to become pregnant, but
Yes.
I think I'm just unclear, like why. Okay, so you're saying this would be like the recommendation would be to not get pregnant during this period.
Yeah, because you need to wash your body from the drug, which can have some deleterious effect on the fetus.
Okay, I think we'll move on to the next week, but thank you very much.
Thank you.